I'm Dr. Allan Perel, and this is Conversations in Medicine. Hi, I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical technology and treatment to the Staten Island and tri-state community. It is my great pleasure to have my friend and colleague, Dr. Adam Smith, here. Dr. Smith is the director of research at the Richmond Behavioral Associates on Staten Island. And thank you so much for being here.
My pleasure.
We're going to talk about dementia. And we're going to talk about the various other psychiatric and psychological problems too. But when we talk about dementia and Alzheimer's disease, just some fast facts. Alzheimer's disease is the 6th leading cause of death in the United States. And between the years 2000 and 2015, deaths from heart disease actually fell about 11%. But deaths from Alzheimer's disease increased over 120%. Our population is aging. People are getting this disorder more and more commonly. We're going to talk about what the difference between dementia and Alzheimer's is and try to give you a little bit of a flavor of what's available in our locale. Staten Island, and some of you might be in the entire New York City area, tri-state area. There are a lot of different areas of research that are going on. And Dr. Smith has one of the most cutting-edge research centers really around, and I think that's a marvelous testament to you and your colleagues. So what we're going to do is jump right in and talk a little bit what you do. So tell me about your training and how you take care of people in your group with people with Alzheimer's disease or dementia.
Yeah, so obviously the first thing that we really need to do, and our referrals come from neurology primary care, but also self-referred as well, is really assess and diagnose the problem. I mean, Alzheimer's disease or dementia is just so different than so many other medical disorders. I believe the average time from symptoms to diagnosis is 3 years. And I'm always hard-pressed to come up with another disorder where the time from having symptoms to diagnosis is so long. Obviously, during that time, the symptoms and the progression of the disease continues to escalate. Obviously, no intervention during that time. When they come to us, some come very early, but most come around that 3-year time period. And I work with a psychiatrist, a geriatric psychiatrist, and the first part of really working with people with this disease is understanding the potential pathology, right? So the term dementia is a very generic term. So what we try to do, as you all know, is come up with a specific cause for dementia or a memory problem. And there are various different subtypes, right? Vascular, which involves obviously blood flow, and sometimes people are vulnerable to strokes or TIAs, transient ischemic attacks. But the most common type of dementia is Alzheimer's disease. Obviously, there are dementias associated with Parkinson's disease, and there's Pick's disease for early onset, there's frontal temporal. So there are many different kinds of dementias, Alzheimer's disease being the most common type.
So we're going to take a step back. As a neurologist, this is my field of expertise.
Of course.
And of course yours too, Adam. I think the idea of dementia is a global term. It's a global term for global intellectual or cognitive decline.
Exactly.
It's not just memory problems.
Right.
It's judgment problems. It's someone not paying their taxes. It's someone not being able to drive. It's not because you don't remember where your car is, but just the idea of where you make your left turn and how to do things appropriately, not being able to do your finances. So there's problems with insight, judgment, executive functions. Some of the things that I see most commonly are multitasking, trying to do 2 or 3 things at the same time as we do in this day and age. So dementia is a global term.
A very global term.
There are a lot of causes of dementia. And as you said, the most common cause of this is Alzheimer's disease. And Alzheimer's disease is a specific pathological disease described by Dr. Alzheimer in 1905.
Right.
And there's certain things that are in the brain.
Right.
You see this bubblegum-like material called amyloid and certain things called tau, that the proteins are not right. Other causes, you said, vascular dementia, where you've had multiple strokes, vitamin deficiency, thyroid disease, all kinds of things that we talk about, hydrocephalus, water on the brain. So we see all those things, and that's why we do a whole diagnostic workup
Right,
for
and
it.
that's going to involve blood work and then with some radiologic exam, like either an MRI
Right.
or
Usually a
CT
picture.
scan. Exactly.
Right. And we get blood work, and we're going to do some neuropsychological testing. And what I'm going to get to you now with this is, once a diagnosis of dementia is made, and if the neurologist, internist, geriatrician, or if they come to your psychiatry colleagues, and patients come in, they've had a process that they've had persistent worsening of cognition for a number of months. Interesting enough, as you said before, most patients will be diagnosed in the moderate stage. They don't come early. And a lot of that has to do with socialization. If someone is quiet and they're not upsetting most of the family, people don't rush to make a diagnosis. But if someone spits or throws things or is very inappropriate, usually they get to the doctor a lot earlier. So
Yeah, there are a number of factors, and we still have to do a lot more education, both with physicians and in the community at large, to sort of help people recognize symptoms earlier, but also to get past some of the stigma that still exists. Sometimes there's a spouse that sort of covers up. Often there's the feeling that this is just a normal part of aging, and so symptoms can get minimized to that extent as well.
Absolutely. So when someone's diagnosed with having dementia after a workup by, as we said, any one of a number of physicians that knows the patients, there are a number of, and maybe you can just go over this, what are the constellation of symptoms that people have, such as behavioral issues and cognitive? Tell us a little bit about those, and how do we attack those?
Yeah. So when I initially started talking about the issue of memory being present and critical to a dementia or Alzheimer's disease, it is one symptom, and it's usually the first symptom that causes people to have a call to attention about it. But there's a whole host of other sequelae or other kinds of symptoms that also encompass these cognitive dementias, and those are the things you talked about. Poor insight, inability to do tasks that they ordinarily had done without thought. Part of the assessment is really looking at how the symptoms and what are the functional deficits from that particular disease for that particular individual. What are the things they're having difficulty doing in terms of independent functioning, whether it be their finances or driving or remembering their appointments. Those are the things that are far more likely to be noticed in the earlier stages of the illness. But as Alzheimer's or dementia persists, other areas of the brain do get affected that impact behavior. And so what you alluded to earlier, people may misinterpret things that are going on, may be overwhelmed by situations that previously weren't a problem for them, and they may become agitated. They may become easily upset. There's impact to sleep, resistance to showering. There are a number of symptoms and behaviors that often can progress as the illness worsens. And that's usually present in the moderate severe stages of the illness.
So tell me a little bit about what you, and I know what you say, I'll say this more rhetorically. As a neuropsychologist, the idea of what you do to discern what abnormality someone has. And even myself, a number of people who've done this for many years, might not actually be able to put someone in a category. And we'll use categories real quick. Normal, aging.
Right.
Then we use, of course, people with dementia, which is pretty obvious where there's been significant functional decline. There's a whole middle ground called MCI, or mild cognitive impairment.
Right.
And a lot of the neuropsychological testing that you do, including IQ testing, speech for language, which can be impaired, judgment issues. Tell us a little bit about those tests, and when if I send someone over, or you have someone that's being done, when would you do these tests, and how do they help?
So it's really important, obviously, as I said earlier, to identify these symptoms at the earliest stages. So as a psychologist or neuropsychologist, there are certain tests that are available to us that pick up the more subtle deficits, and more often than not, memory deficits that let us know that a problem is beginning. Once the disease progresses, we have other kinds of neuropsychological tests to pick up the decline that may occur over time. But what we're looking for when we detect, for instance, mild cognitive impairment are the subtle memory deficits that wouldn't be considered typical for that particular individual given their age and education. So we're looking at sort of a statistical idea about what is a normal amount of problem with memory versus versus more significant issues that start to represent decline. So, there are a variety of different neuropsychological instruments that we use, but we're always, in addition to examining the patient, always talking to a caregiver or a loved one, someone that knows that patient, that can verify and tell us what are the functional problems that that person's having that go along with the psychological testing that we're doing. Because deficits, by taking a test, aren't enough to sort of make a diagnosis or to, there has to be a practical or a functional deficit that goes along with those memory or those testing findings that we have.
And that's so interesting when patients come to my office, there's almost always a caregiver with them. And you ask, are you having any problem doing your finances? The person will say, not at all. And there'll be someone right behind them saying yes, nodding their head.
And so it's just an absolute critical part of an evaluation. And probably from a time standpoint, my understanding of how someone is affected by an illness is much better spent usually with the caregiver proportionally than to the patient. Because almost, by definition, or I think the statistics are almost upwards of 80% of people that have dementia or of whatever type don't have a real recognition that they have a problem.
That insight problem is actually almost part of the disease.
Absolutely.
Your kids will sometimes say, if you say you're crazy, you're not crazy.
Exactly.
That's not really always true. But most times,
for the most part,
patients who have
true.
Alzheimer's disease who come to you saying, I'm very worried about my memory, a minority of those patients will actually have Alzheimer's disease.
Absolutely, and we call those the worried well, but it is important that if people do feel that they have a memory deficit, that it does get appropriately evaluated. And most of the time, those people are family members where their parent or sister or brother has had Alzheimer's disease, and they're kind of getting up in age where they feel that they might be at risk as well.
So let's move ahead a little bit.
Yeah,
we talk
sure.
about diagnostically. Yes, we're going to get an imaging study. We'll do blood work. We're going to get a good exam. We're going to talk to the family. We might do something called neuropsychological testing.
Exactly.
And that might take a week, 2 weeks, get that all finished. Once a diagnosis is made of dementia, and if the dementia type is Alzheimer's disease, which is the most common form of dementia, people come then to me and they say, what do we do? And there are some medicines out there, but the medicines are really not the best.
Right. Aricept, I think it's 6 to 12 months of just slowing down the progression of the illness.
It slows down the clinical findings.
Right.
There's a drug called Namenda out there, or memantine. And we haven't had a new medicine for Alzheimer's disease in over 10 years.
Yeah, absolutely.
And that's remarkable with all the research. There have been many drugs that have failed. So many of the families who come to me ask me, what do I do? And I refer them to you guys. I refer them for thoughts and what other types of things they could do. One of the most important things that people could do on their own is being mentally active.
Absolutely.
Almost like when my kids want to work out in the gym. My son Evan wants to build up big muscles. He goes and works out, gets his big muscles. Same way the connections in the brain do better after you do a lot of thinking. And watching television is not being mentally active unless you're watching this show. Other than that, it's not. But being mentally active, doing crossword puzzles and things like that. So once we have standard therapies, which we know are not ideal, and these are the same therapies that actually someone like President Reagan had 15, 20 years ago. Since we are lacking these new medicines, which hopefully might be coming out in the next few years, tell us a little bit about your research center. You guys have access to things that I don't, or most clinicians in the world don't. And these are drugs, and maybe tell us a little bit what studies are and how whether someone would consider them.
Yeah, I just want to reiterate what you said, because as part of our approach, we're not just all about medicines, and we understand the limitations of those. And I think that's somewhat infused some of the medical community in the sense that they're less likely to be proactive and treat or holistically sort of assess the patient and help them towards research or other kinds of interventions. There's really a passivity with respect to this disease. Yet, if someone had cancer and it was a stage 4 pancreatic where there's a very low probability of good outcome, people will constantly be referred for clinical research and research studies. Somehow that doesn't happen as much with Alzheimer's disease because there's this perception that either because of age of the person or what's the difference that you really can't do much about the illness.
Or as you said before,
treatment really tends to stop very short.
As you said before, people feel it's a natural form of aging, which it is absolutely
it is not. So clinical research, for instance, at our center, we do studies that are stage 2 or 3,
Tell us
meaning
what that
that it just means that it's either it's already been tested in humans and determined for the most part to be safe and without significant side effects. Yet they have to prove the effectiveness of these drugs. So all drugs have to go through a process whereby enough patients can be tested, evaluated to determine that it actually works and is safe. And so by the time we're evaluating at stage 2 or 3, there's already some knowledge that it has shown to have some initial benefit and that it is relatively safe, that they understand the side effect profile. What's typically involved is an evaluation. It would start similar to how you might see a patient in your office with blood work, with either a CAT scan or an MRI. But there's been a little bit more advance made in terms of the kinds of radiologic exams that are available. And as you well know, there's been a PET scan developed with a ligand called amyvid that can help look at the plaque, where previously you weren't able to see
So you take a picture of the amyloid in the brain.
Exactly.
And you can tell by how much is there, whether there's a very strong likelihood someone has Alzheimer's disease or not.
Likelihood.
Yeah.
Not a guarantee, or it's not a definitive way of making a diagnosis. But then the clinical trial, if people have a positive PET scan, the medicines that we would use to treat the Alzheimer's would try and attack that plaque that's seen on that picture on the PET scan. So if people don't have that plaque in their brain, then they, for the most part, wouldn't be eligible to participate and get that medicine because we just don't know the full pathology, and there might be many different pathways towards the development of Alzheimer's disease. This idea of plaque is one theory that exists, and that's where most of the effort is made as far as some of these new medications that are being developed. So the clinical trial would really just proceed once that person showed that they had a positive PET scan for that amyloid to be medicated with a newer medicine that may have some impact on either preventing further amyloid or plaque from developing, or maybe even resolving to some extent some of the existing plaque that occurs in the brain. And that has the biggest likelihood of really slowing down the illness. We're not in a position to talk about reversing illness, however, but if we can preserve quality of life and preventing further worsening, then we've made a solid advance.
So let's take a step back. Interestingly enough, if you thought there'd be a cure for this kind of disorder, you'd almost be there. They've developed these guided missiles called monoclonal antibodies. Those are antibodies that attack proteins. And they, in models of animals and even in people, can dissolve away the amyloid. The problem is it just hasn't shown enough benefit right now. So that's a research tool.
Right.
But I want to, again, what I'm trying to get out to our audience out here, the kinds of studies you do, and you do so many, you're doing medicines that look to hopefully reduce the amyloid load in the brain, possibly be a disease-modifying therapy.
Exactly.
And do most of the patients, two questions, do most of the patients, are they on a placebo side, where half the people get the medicine, half the people don't? And then we'll talk about some of the behavioral issues that you treat so much of.
All right, so that's a great question. For those people that do get involved with these research studies, by the way, they are limiting enrollment for most of these studies to patients that have really either that mild cognitive impairment or mild disease, because they're concerned by the time people already have moderate or severe disease, these medications won't be as helpful in terms of managing the kind of damage that's really occurred to the brain. But if patients are eligible, either having mild cognitive impairment or mild disease, these medications do have a placebo arm.
Which
What
means
that
what?
means is that they're getting, for instance, and the percentages vary, but it's typically about 30%, 1/3, sometimes 1/2 of people will get the actual medication, and either 1/3 or 1/2 won't. And then we track to see which patients basically get better and which ones don't, hopefully with the notion that those people that were on medicine really did better.
So it takes a commitment from the family and the patient to be part of one of these studies.
Absolutely. But we don't restrict. If patients are already on the Aricept and the Namenda, they can stay on that, so that participating doesn't really limit any options that they might already have. Plus, it's it's all voluntary. If there's a continued decline over the course of the study, we encourage patients to either terminate or consider other kinds of options. But I sort of look at the glass as half full. So if you don't participate, you don't have an opportunity to go on a medicine that may in fact be beneficial.
Are these the same medicines that are available, say, in Manhattan at some major tertiary centers? I know you've done a tremendous amount. I basically know the answer that you do have it, but
Right.
please tell our audience that the availability of some of the most cutting-edge treatments are
Yeah.
available on Staten Island, and really don't have to go to one of the tertiary centers to get them. So tell us a little bit
So
about
what's
it.
interesting about it is all this kind of major pharmaceutical research work, really 15 to 20 years ago, even up till then, was being really done at the major academic medical centers. But pharma's moving a lot quicker today, and it's often harder for these pharmaceutical companies to do these clinical research studies in these large academic institutions because they take so long to get through their bureaucratic process to the patients. So most of these studies are really getting done in community doctors' offices around the country. And aside from one or two other centers in the metropolitan area, I'm not really aware of a lot of research centers or physicians' offices that are doing a lot of this clinical research. So we are lucky here, I think, in Staten Island. And many of our patients come from Long Island and New Jersey because these studies really aren't available everywhere.
Let's talk about some other things.
Yeah, sure.
You mentioned that your center, really unbeknownst to me, is doing some major research right now in autism and a few other things. Maybe tell us a little bit about it.
Well, look, we are a general psychiatry practice, but a big part of what we do is just looking and being involved with clinical research for medicines related to psychiatric and some neurological disorders where there just aren't good treatments developed, or there clearly needs to be improvement to some of the treatments that are already out there. Autism, we don't have to remind everybody, is just for some reason a growing percentage of the population. So the statistics vary, but if anywhere from 1 in 65 to 1 in 100. And for some reason, whether the diagnoses were different, it just wasn't at this incidence, or this there weren't these numbers years and years ago. Understanding again the pathology of what causes autism is still very unclear. We've been involved probably over the last 8 years in evaluating standard medicines in psychiatry and seeing how well they can work for behavioral problems associated with autism. Some of the agitation, some of the impulsivity. Medicines that people might know, like Abilify or Latuda or even Risperidol. I'm happy to say that
Those are fraught with side effects.
and they're
issues.
fraught with side effects, and it's just for the behavioral problems. More recently, there has been more attention paid to this illness and trying to get at the underlying core symptoms of what autism is. So that it's a syndrome involving one's ability to communicate appropriately and understand communication and be able to converse, and also the socialization aspects of what we all take for granted in terms of social interest, understanding social boundaries, and interacting. And so those are what we consider the core symptoms of autism. And so last year we were approached from Roche that has developed a medication called Balovaptan, and it's really the first medication that has been developed to look at the core symptoms of autism, meaning the social and communication issues. And the whole premise of this medication is based on the premise that with patients that have autism or people that have autism, there's an imbalance between vasopressin and oxytocin.
Those are two chemicals, those are
two
chemicals
hormones that we all
in the
have,
brain,
right? And it's sort of, oxytocin is known as sort of that hug drug, or a hormone that has been implicated in terms of promoting social kind of function. And so they feel, the research has sort of hypothesized that those levels of vasopressin and oxytocin have sort of been out of whack or not balanced. And so this is a medication that is really attempting to kind of balance out that vasopressin and oxytocin, and then subsequently see what the impact is to sort of the social and communication
Is that a placebo
functioning.
study that you have there too?
Again, that is. Now, they've had some success with it with adults, and we're actually working with not only children that have autism, but they feel that there's been positive enough results that we're looking at this in adults as well. So we did a 4-month study with children that have autism that's placebo-controlled, but after that 4-month period, everybody can go on the medication in what's called open label. The same thing is going to occur with adults. So it's going to be a 6-month double-blind, meaning 50% are going to get medication, 50% placebo, but once that 6-month interval is over, everyone's going to be eligible to go on the medicine. Now, we're not talking about, like most treatments for most medical or psychiatric or neurological disorders, the first medication's never a home run, and no one should ever promise results with anything. I think with this particular medication, they're looking at a slight bump of 20 to 30%, if I can put numbers to things, to try and improve actual function when we look at social and communication aspects of the
any
disorder.
improvement is something that we look for.
Right, with a low side effect profile. So this is how we sort of move the bar to a great extent. And we've been fairly successful in terms of enrolling and getting patients and families involved. But we're very careful. Families, whether it be children or adults who have autism, the parents are very desperate for anything. And they're also mistrustful of the medical community, whether it be their feelings about the implication of vaccines and whether...
Which has proven not to be the case.
Right, exactly.
So please, there's been a whole issue recently about not giving children measles vaccines in different parts of New York. The science is overwhelming that vaccines are not the cause of autism.
Exactly, but there's still, there still is a mistrust, and so I think sometimes we often find that we have to do a lot of really just discussion around those kinds of issues to get families to be comfortable and let them know that we're listening to their concerns and are interested, kind of in their feedback. Because just some have had negative experiences.
Sure. I want to thank you, Adam. Dr. Smith and I have been together for many a time, and really just want to put a shout out to David Marcus, our producer, for his wonderful work. And Adam and I have done many a show with Gladys Schweiger, who used to do a show called about Alzheimer's disease.
Yes, Alzheimer's awareness.
Alzheimer's awareness, and it was really a wonderful show bringing this to the community.
Yeah, and she was sort of a way of, such a force that allowed all the people working with Alzheimer's in the Staten Island community to kind of coalesce and share information.
And in a sense, we're in somewhat of a continuation of the show that we have.
Yes.
And it's marvelous. I want everyone out there just to really know that how many of these cutting edge technology that we have available to us locally, both from your physicians, both from the research that Dr. Smith is doing. Really, it's a pleasure working with you, and we love sending patients over to you because they're really taken care of so well, and want to say thank you for coming out here and again helping us treat this very devastating disease. Thank you.